thank you for the invitation to this conference. We show the clinical outcome reconstruction with tissue expanders for patients with breast cancer and mastectomy. And additionally, we analyze the complication of reconstruction with tissue expanders. The incidence of breast cancer is increasing in Japan. Therefore, improvement in post-operative quality of life is a very important issue for breast cancer patients. We determine whether or not reconstructions with tissue expanders and permanent implants affect the prognosis or local recurrence rate and increase in the infection rate. This study included the patients who had undergone mastectomies for primary unilateral breast cancer in our hospital between 2000 and 2009. 197 patients who had immediate reconstruction with the Ts as T group, and 540 patients who had mastectomy as MT group were included. Antibiotic was administered before operation based on the guidelines. J-Bacterium was inserted into the regional axilla. An infection was diagnosed in patients with extensive erythema, high fever, pain, or tenderness at surgical site. The types of tea varied between 2000 and 2006. We used cocaine teas. And from 2006 to the present, we use elegant teas. This slide shows patient characteristics. Some selection bias were recognized because this study was retrospective. Patients in the T group were younger and more likely to have undergone sentinel lymph node biopsies. Adjuvant therapy and metastasis were compared between two groups. No significant differences were observed with respect to the frequency of chemotherapy, endocrine therapy, and metastasis. The PMRT rate in the T group was significantly lower than the MT group. This slide shows the clinical pathological findings. The frequency of T4 disease and invasive cancer in the T group was significantly lower than the MT groups. The local recurrence rate was analyzed. The local recurrence rate in the T group was not different than the MT group among all patients or patients with invasive cancers. Similarly, the local recurrence rate in the T group was not different than the MT group among patients with or without lymph node metastasis. This slide shows a univariate and multivariate analysis of local recurrence. Reconstruction with the T was not risk factor for local recurrence, and therefore never contributed to the local recurrence rate. The relapse-free survival was analyzed using a Kaplan-Meier method. RFS in the T group was not different than the MT group for all patients or patients with invasive cancer. The RFS was analyzed among patients who are hormone receptor negative or positive. RFS was not different between two groups. RFS was analyzed among patients with or without lymph node metastasis. RFS was not different between two groups. Similarly, overall survival was analyzed. OS in the T group was not different than the MT group for all patients or patients with invasive cancer. OS was analyzed among patients hormone receptor negative or hormone receptor positive. These results are the same as the RFS. This slide depicts the overall survival among patients with lymph node with or without the lymph node metastasis. RFS, the OS was these results are the same as RFS. This slide shows the univariate and multivariate analysis of RFS. Reconstruction with the TE was not a risk factor for RFS and therefore never contributed to the prognosis. The incidence of infection was 30.2% versus 4.1% in the TE and the MT group, respectively. The incidence of infection in the T group was significantly higher than the MT group. This is a univariate and a multivariate analysis of infection. Multivariate analysis showed that actual clearance, BMI more than 25, and reconstruction with the T were independent risk factors for infection. This slide shows a summary one. Compared with the MT group, immediate reconstruction with the T's did not reduce the RFS and OS. Based on the univariate analysis, reconstruction with the T's was not a risk factor for local recurrence and RFS. The incidence of infection in the T group was significantly higher than the MT group. Multivariate analysis indicated actual recurrence, BMI more than 25, and reconstruction with the T's were independent risk factors for infection. This is a map of Tokyo. Mitsui Memorial Hospital is located in Chiyodaku. Our hospital does not have a plastic surgeon on the staff. If a patient who requires a mastectomy desires reconstruction with the T, we recommend she consult a breast surgery clinic, which is a separate institution from our hospital. We usually perform mastectomy concurrently with reconstruction using T's. An exchange to permanent implant is performed at the breast surgery clinic, which is in Shinagaku. The distance of between two institutions is approximately 9.0 kilometers, which takes approximately 25 minutes by train. Breast surgery clinic members are shown on this slide. Dr. Yoshiko Iwahira is an experienced and highly regarded plastic surgeon who specializes in breast reconstruction. Additionally, we analyze the complication associated with immediate reconstruction using T's and PIs. We evaluated the incidence of infection that occurred at the surgical site. The surgical site associated with immediate reconstruction that requires removal of T's or PIs. We retrospectively studied 233 patients undergoing post-mastectomy breast reconstruction between 1997 and 2009. There were 233 patients who had 239 reconstructions. Simultaneous bilateral reconstructions occurred 3% of cases, involving 6 patients. This slide shows other patient characteristics. T4 disease involved 3% of cases and 8 reconstructions. This slide shows causes for removal of T's or PIs. Removal of teeth or PIs were observed in 50.5% of all reconstructions. 7.9% of reconstruction failed. The most frequent reason for reconstruction failure was of TE infections. The completion rate among all reconstruction was 92.1%. This slide shows the correlation between the infections and failure rate of reconstruction. The reconstruction completion rate among patients who had teeth without infections was significantly higher than in patients who had teeth with infections. This slide depicts relationship between risk factors and TE infections. BMI more than 25 and zero mass pressure were risk factors for TE infections. This slide shows a multivariate analysis for infections, TE infections. Zero mass pressure was a significant independent risk factor for TE infection. This slide shows a summary too. 50.5% of reconstruction result in removal of teeth or PIs. 7.9% of patients declined reconstruction. The most frequent reason was infection of teeth. The reconstruction completion rate among patients who had TE without infections was significantly higher than in patients who had teeth with infections. Zero mass pressure was a significant independent predictive factor for TE infections. Following conclusions arising from our study can be stated. Immediate reconstruction with the teeth did not contribute to local recurrence or affect prognosis. Indeed, reconstructions with the teeth represent a key operative procedure to achieve curability and the desired cosmetic results. To improve the reconstruction completion rate, it is important to prevent T infections, and inhibition of telomer formation is needed. Our work has been peer-reviewed and published. Thank you for your attention.
Okay. The next speaker is Dr.